Welcome to the latest webinar presented by the CMT Association. My name is Rick Albert and I co-moderate one of the support groups out here in California. Today's webinar is entitled Why People with CMT Get Prescribed AFOs and What the Orthotics Are Supposed to Do. We're very fortunate to have Sean McKale here to share his knowledge with us. Before I introduce Sean, I'd like to explain how the webinar works. Each of the attendees should see a large window on their screen displaying the first page of Sean's PowerPoint slide presentation. Sean will advance his slides in that window as he speaks. Next to that window, you should see a smaller window displaying Sean's video feed. You can change the size of both these windows if you wish. You should also see a webinar dashboard window, which contains a question area where you can type in questions during the webinar. Following this presentation, Sean will address those questions, and you can use the question area to address any concerns about the webinar, such as volume levels or window display problems or whatever, to me while Sean is speaking. The webinar is being recorded and will be archived at the CMT website at cmtausa.org under the Resources tab on that website's homepage. It will take about a week before the recording is uploaded to the site, but once it's there, you'll be able to see Sean's slides and read a transcript of all that is said during the webinar. The video shown of Sean during the webinar is not recorded and will not be part of the archived recording. Today's webinar should run just about an hour in length, maybe a little longer. Sean McKale is the practice manager of Midwest Orthotic and Technology Center in Chicago, Illinois. Sean began as an athletic trainer whose love of working with his hands eventually led him to the field of orthotics. He has worked in various clinical settings, but through his time spent at the Rehabilitation Institute of Michigan and his relationship with Dr. Michael Shai, he has become increasingly passionate about helping patients with neuromuscular involvement. Sean has spoken at numerous national orthotic and prosthetic conferences about dynamic AFOs, CMT, unique case presentations, and the management of pediatric patients. I'd like to now turn the webinar over to Sean.
All right, thank you, Rick. First of all, it's my pleasure to be able to talk to everybody today. Obviously, a little strange being that everyone can see me and I can't really judge the reaction of my audience today, but hopefully we're able to answer a lot of questions for people in regards to the use of AFOs. Okay, my slides aren't advancing. Oh, there we go. All right, so today I'm just going to quickly go over and review some of the gait deviations involved with CMT that lead to the prescription of an AFO, what some of the goals for an AFO should be for you as the patient, some of the challenges and why that becomes difficult for orthotists when we deal with patients with CMT. Some discussion on the different materials that AFOs are made from and how that impacts the different designs. And then I'm going to spend the majority of this presentation just answering some of the submitted questions that were sent in. And a lot of the questions are very similar to what we would receive normally in the CMT clinic that I used to attend with Dr. Shai. So I think they're a good sampling of really what a lot of people have similar questions with, and even in some of the questions we received there was some redundancy, so if you don't see your question exactly written the way you had typed it or written it, it's because it's probably in the spirit of another one of these questions. And then hopefully at the end, if we have some time, I can answer some further questions. I do have to get home and relieve the babysitter tonight, so I'm going to try to stick as close to an hour as possible if that all works out. So to start with, this is a patient of ours who walks with pretty significant drop foot, and obviously he has a diagnosis of CMT as well. So from a gait analysis standpoint here, we look at his foot progressions. Instead of getting a significant heel strike, heel-toe progression, he gets more of a toe, heel, and then a slight reversal then as his body weight goes over the top of his foot. As a result, he's also walking with increased base of support, so his width of walking is wider than what would typically be considered normal for someone his size and age. Also, you can see the insides of his toes. A typical walking progression, when you look at someone walking from the back, you would expect to see the lateral two toes, or the fifth and fourth toe. And obviously, when we look at this gentleman from the back, we're looking at his first toes hitting. So that, to me, says we have significant internal rotation. A lot of CMT, you'll hear the term supination, which really is in regards to the rolling outward of the ankle. Our body is divided into 3 planes of motion, and the ankle doesn't just move up and down, or what's known as dorsiflexion and plantar flexion. It's also rolling from side to side, which is called varus and valgus, and transversely, internally, and externally rotating. So sometimes a clinician or a doctor might say that CMT is a triplanar deformity, and what that means is, as the CMT progresses, it's not just one of those planes that's affected, it's all 3 of the planes. In normal progression, the intrinsic muscles, or the short muscles of the foot, start to change first. And because of that imbalance, that's what heightens and widens the foot. So the arch heightens, the foot widens, and the toes may or may not claw as well. That's all because of an imbalance in the shorter muscles that don't cross your ankle but are just located inside of the foot. This can cause some rolling of the ankle as well, but really the rolling of the ankle starts to begin when the imbalance of the muscles that help lift up your foot start to weaken. And the muscles that are on the lateral or outside of the leg that help to do that initially first, upward, that are located and attached more medially or on the inside of the foot. As they lift up, that helps to twist because they're outpowering a now weak muscle on the outside. So even though you may not have so much of a drop foot that you're consistently catching your toe, having some lateral weakness around the ankle prevents perhaps good placement of the foot on the ground when you heel strike. And it can also be fatiguing because you're supposed to have several muscles helping that motion, and when you have a decrease in the lateral muscles that were helping that anterior muscle do its job, I'm trying to not be too technical, sorry if I am. If some of those muscles that have to lift up the ankle are becoming diminished, then that starts leading to some twisting even before maybe you have a significant foot slap as well. So that may be someone who's more mildly involved who may still also benefit from an AFO as well. When we start to have weakness of lifting up our ankle at all, there are a number of things that we naturally do to compensate. And because this is chronic and very slow in nature, our bodies start to find these compensations, and they do so rather easily and quickly, such as taking a shorter stride length. If you take a shorter stride length, then you don't have to use as much energy through the swing phase of gait to lift up your foot because it's a shorter distance till the foot is on the ground again. You may also start walking with increased flexion at your hip. So by bending your hip more when you take a step forward, that brings your knee up higher. It also means that your foot is clearing the ground higher. So the ankle that may not be lifting properly is being lifted from the proximal end or up by your hip so that you have clearance. And that's also one of those natural compensations that no one told you to go lift your hip higher. But it does use more energy, and it also as well can create then some other issues for you in terms of biomechanics and how your body feels, for example. This gentleman has significant weakness, and you can see that even though his muscles I can tell you he has pretty strong muscles at his quads, and but we do notice as he's walking he's got some sway to his trunk. That's because of some of the shortened stride length and shortened stepping. He's not firing his glutes or the extender muscles in his rear end quite the same way that he would have if he didn't have quite so much involvement below his knees. So as a result, he's turning off some of that muscle group, and that's causing some of this sway to happen as well. So even though the CMT or the nerves in those muscles more proximal or in his hips aren't necessarily involved because of the CMT, directly because of the CMT, they're indirectly involved because of the mechanics by which he walks have caused him to develop certain compensations to advance his limbs. So that's, you know, some of the deviations that occur. Additionally, looking down at the ground because we have proprioceptive losses, which means proprioception is the understanding of where your foot is in space. As that is lost, using visual eyesight helps you to gain information, so you start to understand where your foot is on the ground. How an AFO can help that is because it touches a higher portion of your leg, say your calf area. What that is doing is bringing the ground up to you, so it gives you another sensation, so a touch sensation that helps you to gain that proprioception or understanding of where your foot is. So that can be an indirect benefit to wearing AFOs as well. For some extent, there are some patients with CMT who present with very good strength. They can lift up their ankle quite well and push down quite well, but they have significant proprioceptive loss. So if they close their eyes and you ask them, did I lift up your ankle or push it down, they really couldn't tell you. In those cases, sometimes wearing an AFO for those patients helps because of that proprioceptive return or getting that information to a part of their body where they can understand better that the ground is now in this place. And because of the connectedness between the AFO and touching the back of the leg, that can be of some benefit as well. So, so the goals of the AFO should be a number of things, and this is just, you know, what I wrote down last night as I think when I talk to patients with CMT. We want stability, so one of the first things we do when we try on a new set of AFO or any type of orthotic with CMT is we ask someone to stand up, and we ask them to close their eyes when they stand up, and you know, we hope that they have better balance, and really you should be able to do that inside of your AFOs if they're accomplishing that goal of providing you better stability and balance during not only gait but during static standing, and that has a significant impact on energy expenditure as well if you're able to stand still versus have to do all these micro corrections in standing and in balance. Improvements in biomechanics, so including the alignment of the joints. So by aligning the joints better, we hope to have less stress on the joints. You're hoping that you're helping somebody to have increased step length, having some equalness to their walking, because often there's a limb that may be more affected than another limb. Decreased energy expenditure because maybe you're not using as much effort to stand still. Maybe you can walk for a longer duration as a result of that's increased activity level. But you know, you're not having to focus so much on your walking, so you're able to use less energy then as a result of that, and increased safety as well. So not only are you hopefully feeling more confident in terms of your ability to walk safely, but because you're more stable, but also that you wouldn't turn your ankle then and be susceptible to a sprain or an injury in regards to that as well. All of these goals really being to enable you to do more, hopefully, and not to disable you and do less. That's hopefully if the orthotic is accomplishing what your goals are set in mind. So I think it's important you know, as orthotists, to understand what those goals are for you as a patient, and to understand how we're going to accomplish those together. So these are, so part of the significant challenge with CMT compared to other diagnoses is because of the triplanar deformity, we think about the ankle and the primary motion being lifting up the ankle and pushing the ankle down, but we can't disregard those other two planes of motion, so the transverse internal and external rotation, as well as the side-to-side position. And these are both good cases here. One on the left, which is more of a classic supination or rolling outward of the ankle. You can tell the alignment on that is significant, and if we have to do significant correction there, it's going to be harder to add a lot of dynamics in the plane of sagittal movement of up and down, dorsiflexion, plantar flexion. In the case on the left side, it's actually somebody who does pronate their ankles in, and we certainly do see patients with CMT who do that. It's not as commonly frequent, and this child actually is still early on in terms of the progression of the diagnosis. If his father wasn't diagnosed, it may be not, he may have not received the diagnosis of CMT yet at this age. And it could be as the intrinsic muscles of his foot change more, he may end up looking later on in life more like the child that we see on the left. But at this stage of his life, he's collapsing towards that in-range position, and as a result having trouble with pushing and jumping, but he's still able to lift up his ankle and push down. But creating that force is difficult because right now he's standing at an in-range position, and that's difficult to generate the force to start something like jumping. So an orthotic design for that individual is more of something shorter that would help correct the side-to-side position, not necessarily an AFO at this point. Anyway, but that's why orthotists have trouble with CMT feet. It's why AFOs break, because most AFOs are designed to be dynamic and moving in the direction of dorsiflexion and plantar flexion. And when you add in forces transversely and coronally, you're putting stress on a system that is really designed to bend in one way. So this is always the difficulty of, well, I want something dynamic that really allows me to do this and this. If that is possible, then absolutely we'll make those attempts. But sometimes if the control is really important, you have to outweigh, you have to understand the issues. Some of the issue with breaking AFOs too is, well, maybe the orthotist didn't do enough to control these planes of motion, so that transverse plane of motion or the coronal plane of motion aren't being controlled well enough to maybe manage some of the stress that the patient is putting on those AFOs. So that leads to failure. And maybe if things were done a little bit differently from the beginning, then the AFOs themselves wouldn't have been failed well. So I will address that a little bit more as we get into some of these questions. So, so as far as material selection goes, there are lots of tools in the proverbial, you know, in terms of what we can get to and use as orthotists. Most people are familiar with plastics and polymers. There are different types of plastics. There are more rigid and softer plastics. You know, sometimes the thing that people don't understand with some plastics, so we could have a brace that's pretty stiff, and this is a solid ankle design, and it's stiff if I try to push it forward, and I can't lift the toe up. But what I can do is I can transversely rotate this brace pretty well, and you know, again, controlling all three planes of motions, that's one of the disadvantages of using polymer systems, at least in a single layer system. We can do something with plastics where we inlay carbon inserts, or we put corrugated roping or other material inside of there that causes some of that transverse rotation to go away. But that's part of the motivation for staying away from some plastics. If you do make it more flexible, so you could trim this AFO, for example, back more posteriorly, and then it would bend more forward in dorsiflexion and plantar flexion, but you would overpower that somewhat quickly. I'm trying to think if I have a sample handy to show you. Or the other disadvantage is that the more you bring these trim lines further posteriorly, you increase the rotational aspect then of the orthotic as well. So that's some of the issues with plastics. You know, then there's a lot of, well, what thickness do I choose for the specific patient? How do they stretch that plastic? Do they stretch it more in one part of the brace versus another part of the brace? There's this design that was made in Canada called the ESR, which is three layers of plastic inside of it, and it's actually very dynamic. It's very flat in the posterior aspect, and what that does, let me try to lower that a little for you. What that does for us is it as you bend your knee or come forward on the plastic, it loads the material, so you're adding the energy into it, and then when you unload it, that's when it springs back and gives you that energy return. So it's quite possible to get energy return from polymer systems, but very specifically, this is a very rigid system. It's got 3 layers of plastic melted together, 2 different types of plastic, and you know, has its advantages and disadvantages as well. Because of that, though, transversely, so I can't really rotate that foot underneath the strut because of that added additional stiffness. So those are considerations, I guess, that the orthopedist has to make when working with those type of materials. Carbon fibers, there's a wide variety of types of carbon fiber bracing, and there's lots of carbon fiber bracing questions as we go along through the presentation. Sorry, thanks. But carbon fibers can be very strong. This is a carbon/glass hybrid system called the fat brace, which I'm going to get to a little bit later on. This is a more flexible carbon fiber material, which has obviously got a lot of return, but maybe not as stable then in standing aspects. I think a lot of people have heard of the blue rocker systems, for example, obviously a lot stiffer, more dynamic through the foot plate in terms of the aspects of return. So let me angle that down. So when we step, it helps to soften and lower the foot down to the ground, then it's stable over standing, and then it helps to spring. Do not do this on a tabletop. Then it helps to spring and push off. So that's how the dynamics of that specific device work. So carbon fibers are very different too in terms of how you lay them up. So if you cross them, how many layers you do. Do you put them all in a unidirectional pattern? There's a lot of decisions in terms of what we're making inside of a carbon fiber brace, and each one has got its own very specific specifications. I would say that just as a caveat, or if we really want to talk about more specific AFO designs, there was a conference we did in Orlando where David Meisner and myself spoke at, and at that conference we went into a lot of different designs and some pros and cons and specific things about each one. That conference isn't yet on the CMTA website, but it will be shortly. So anyway, I'm not getting into too many specifics about specific designs today, but if you want more details, that's another place to go. Metal systems, there are patients with CMT who were still using metal systems, and by that I generally mean there's a shoe attached to a metal upright brace with some kind of calf corset or calf band. That can be used for the reason of fluctuating edema. So some people deal with other issues such as lymphedema or significant fluctuating edema. You can imagine in some traditional AFO designs, if you're swollen one day and you need to fit into this brace, you may not fit into it the next day. So, you know, that's a major issue for some patients with CMT. So it's something to think about or consider. So, leather systems or Gauntlet type systems, I would say the other and very similar to that are silicone systems. This is a synthetic, it's not a leather, but it's a substitute for those leather systems. These are traditionally used when there's orthopedic reasons or in place of people who really need like fusion and aren't looking for the dynamics, because anything dynamic is causing them orthopedic pain. So that's a little bit different, but really when we're trying to lock up the ankle perhaps. So this is like a molded lacer boot that can be done with laces or with Velcro straps. Instead of the laces, you can use these Velcro straps. A disadvantage to doing the Velcro straps, say all the way to the bottom, is that you have issues with fitting inside the shoes because of the bulk. So one of the advantages also to the laces is it's very nice if you have volume fluctuation issues, which often people with orthopedic concerns at the ankle may have. So, you know, and I hope I'm not confusing anyone there. So,
Sean,
yes.
Sean, when you're using the term orthopedic, what does that exactly mean?
Sure. So what I mean there is there might be something like more of a fracture issue. There might be an arthritic issue, something besides more with the bone itself. So something inside of the ankle joint which would lead a surgeon to say we should fuse this ankle. Now, what can be a little confusing about that is there are also surgeons who would say let's fuse a CMT ankle even though there isn't an overwhelming orthopedic reason to do it, but a weakness issue. In general, we try to avoid that situation and feel that a lot of people who don't have the orthopedic reasons can do very well with bracing solutions or orthotic solutions. So is that clear enough, Rick? Do you think? Clear as mud?
No, that's good. Thanks.
Okay. All right. So, and I put oh my because obviously, if you don't know George Takei, that's his big saying. But obviously, there's a lot of decisions here, and you know, to say that every CMT patient I see receives a carbon fiber brace would be absolutely wrong. And really, it's that discussion of, well, what are your needs? What do you want to do with this? And you know, what shoes are you going to want to wear? What's going to be the right decision or solution for you as a patient as well? So, you know, your orthotist has many tools in their toolbox, maybe beyond what they're per se presenting to you. So, I guess it's important to make sure that there's some discussion to know, you know, well, how am I going to put this thing on and off? You know, those sorts of things. If you have hand issues, for example, and they're wanting to put you in something that's all laces, that may be of some concern, you know. So ease of donning, putting it on, that's an important discussion, I think, to have before AFO is made as well. So, so I'm getting into the questions, and actually this is a good segue into really maybe explaining a lot more of the general talk, and I think that I use these questions to really illustrate rather than you know, just talk about AFOs. So I think this was great that we got so many questions sent in. So some people put their names on things or very specifics about themselves. I'm not necessarily going to talk too much specifically. Sometimes I'll be more generic, but I did omit names just for privacy reasons as well too. But Anyway, so how long will the use of orthotics be a benefit to a person who has CMT2? Just to address that first part, I mean, that can vary on how involved you are as a person with CMT2. So some people are more involved than others. I think the question may be, how long should an AFO reasonably expect to last? And from the next standpoint, how often can a person update a new orthotic under Medicare? So some insurances do allow patients to come in once a year and get new orthotics. Medicare currently requires 5 years between a set of AFOs, with the exception of if there's been a change in condition. So if your condition has gotten any worse, which with a progressive condition that's generally the case, it's just that there has to be some documentation from your doctor indicating that. If a brace is lost or stolen, also has to be documented by the physician. Or if a brace is no longer sufficiently meeting the needs that it was previously. So also all important things to be documented by your physician. Now, Medicare has started doing these audits that have required orthotists, including myself, to be very cautious about supplying AFOs to them. And the reason why is they're going back and they're doing these audits and they're looking at the physician's notes to say whether what we did was justified or not. So whether our notes are detailed to what the condition is and what changed about the patient and everything, unless it matches with the physician's notes, they could come back and take that money back from us. And they're doing that more and more because, you know what, they like to get their money back. So as a result, what that is causing us to do is, after we do an evaluation with the patient with CMT or any diagnosis and they have Medicare, we send a letter to the doctor explaining that we need their most recent clinical notes that explain the condition, and then we evaluate those notes and we see if there is the evidence that Medicare is looking for or not, and then based on that, if there isn't, we help to educate the physician with some of what they need to add in there and wait until it does get added before we can deliver that AFO. So certainly making the process a little more complicated, but also probably important to the treatment of the patient. So sorry, I'm advancing not on purpose. Go back. Sorry. What other treatments can a person with CMT2 make the useful life of the orthotic last longer? So again, I don't know that this is specific to a CMT2 patient because not all CMT2 patients will present identically to one another. You're each unique, and also you may not present too differently from a mechanical standpoint from a patient with a different type of CMT as well. The question is, where in the progression are you? And really, for me, managing the transverse and chromoplanes are important considerations in making the orthotic last the patient longer. Okay, so go on how I do that a little bit down the road here. How do you know which type of orthotic is appropriate? I've seen ads recently for carbon fiber orthoses and claims showing an actual patient using them during a half marathon. Is this realistic? Currently, I can barely walk around a flea market using my hard plastic orthotic braces. So first of all, if you're having trouble walking in your orthotics, it's probably time to reevaluate that and see if there isn't a better solution for you in terms of either something that is more dynamic and can move better for you, or is possibly of a different design. The reason people like the carbon fiber braces is that they are dynamic. Now, things that move break. And when we walk and we use them and run and do all of these things, living an active lifestyle can cause things to break. So I don't know that I see that as a bad thing. I mean, it certainly is. We'd like everything to be invincible to that, but eventually, you know, we would hope that every orthotic lasts the patient close to 3 years. You know, there are certainly some patients who, because of their mechanics and because of their lifestyle and activity level, are lucky to get a year out of a brace. So, you know, the question is it worth going into something less dynamic? For me as a practitioner, this is my question. Do we make the sacrifice and go to something less dynamic, or do we keep with something that has some dynamic movement to it? And that's a tough decision, and it's finding the right balance. And that's a challenge because there are lots of carbon fiber bracing options now. There are lots of plastic options I showed you a little bit of, but the point of this, though, is that there are a lot of options. You got to find the right one to match each patient, and that is the true challenge. And even in the similar bracing structures, so if we make a noodle, for example, it's my responsibility as the practitioner to choose what level of stiffness I request from the manufacturer. So I have to judge that based on how unstable the person is and how active their lifestyle is. And so the history is very important to me in that decision. And I guess that's where, you know what, we don't always get it 100% right. And I don't think it's easy or possible to be 100% correct on that. What I do know is you can learn from the experiences. So you can learn from when someone has broken a brace rather quickly. Okay, we need to make some different decisions and go in a different direction. And you know, I think there's obvious reason for all of that. So I have the piano on here because I grew up with a home that had a piano in it, and I do not know how to play the piano at all. So my point of that, though, is just because you see people with CMT out there running in marathons and half marathons doesn't mean that those individuals didn't put a lot of work and effort into becoming half marathoners, and they should be applauded for that. And just like I myself am not much of a runner before now. I used to be a runner, but the point of that is I wouldn't expect that tomorrow I could sign up for a half marathon and run it this weekend. I might expect that in September or November I could do one with training in between. For someone with CMT, maybe that goal is a year or 3 years or 5 years away. I don't think you can just buy the carbon fiber AFO and expect to be able to run the half marathon. So that's the piano reminded me to talk to you guys about that, because my I can only play do, re, mi on my right hand. So anyway, I hope that answers that question. So okay, in terms of the person who asked this question specifically, I would say certainly the beautiful part about some of the carbon fiber AFOs is they're off the shelf. So speak to your orthotist and trial them. The other caution I would say there is everyone walks funky when they first start in them. So see if they have a demo set. I have demo sets in my office. Potentially I can let patients even take them home and work with them a little bit. But I also generally, you can spend enough time getting used to them in an office to experience, oh, this is how they're different, this is how they might help me. So take advantage of those off-the-shelf ones. Even if they might not be the end solution for you, they at least give you a sense for what this is all about. So my neurologist and podiatrist both agree that if I start using braces, I will not be using my muscles and that is not good with CMT because I need to keep what muscles I have working. They say if I don't use them, I will lose them. What are your thoughts? And then we had several questions kind of along this same line. So there's no evidence, medical evidence, indicating that this is in fact the case. There was a study done back in the 70s that took healthy athletes and they put them in solid ankle AFOs, and they had them walk around and they looked for this, if there was strength decreases, and they didn't notice any strength increases. And some of those athletes, they actually did phenol injections, so they paralyzed the muscle by putting it with phenol. This study could never be replicated today because of consent, and as well as you potentially could have caused harm to these individuals. But in the end, though, none of these athletes were having any further loss in muscle use. Now, that doesn't necessarily relate to somebody with a neuromuscular issue. I do have some feeling to this, and I do feel that when braces are made to an in-range position, meaning they're lifted as high as your ankle can possibly go, that does limit the force production that the ankle can push down inside of the AFO. I have a patient coming up here that, in a video that I'm going to illustrate solid ankle versus hinged ankles. And in that particular case, when we put patients not at their absolute in-range, there has been a study that did show that patients were gaining strength when they're not at an in-range position. So although there hasn't been a study showing that patients lose strength because of AFOs, there has been positive correlation to actually gaining some strength. Now, a patient with CMT doesn't necessarily gain strength because the reason the loss of the strength is there is because the nerve isn't communicating to the muscle any longer. And sometimes what this picture is reminding me of to talk to people about is, you know, people feel this because they're now getting an AFO, they're getting weaker, but they're also at that stage of progression where they've made the decision to get an AFO, or someone has recommended to them to get the AFO. So they're at a point in the progression too where that has become or made logical sense for them. That is where, you know, sorry, Rick, I looked at your question. I'll get to that at the end. Sorry. That's the point in the progression that they're currently at. So, you know, we want to. You have to realize that there's a progression to the disease and as well, and that partly you're now at a point where you're interfacing with an orthotist. It may be somewhat coincidental or correlative to the fact that you're progressing and becoming weaker anyway, to some extent. Okay, I think dynamics help prevent that. So a brace that is more dynamic compared to one that is less dynamic. But to the point of what the neurologists and podiatrists are telling you, there is no empirical evidence for what they're saying. So I know that's a little confusing. In some sense, you're explaining apples and oranges when we speak about AFOs too. So to say an AFO isn't very descriptive. AFOs are thousands of different things, and even to one individual, they're different things because range of motions can be different. Triplanar deformities are different. So it's really it's a difficult answer. It's a difficult question to answer on a broad basis, to be truthful. So this question is: diagnosis in 2005. I'm a 74-year-old with relatively mild symptoms, which include scoliosis, some motor nerve loss in my feet, claw toes, and prominent calluses on the balls of my feet. Regarding the calluses, which I care for occasionally with an emery board, would they be helped by some type of shoe insert? I don't have foot drops, so I don't think I need a full orthotic. I do have slight supination in my left foot. So, okay. So if there isn't difficulty lifting up the foot, then it's quite possible that a foot orthotic is significant enough. What I would say is alignment is important no matter what level of support. So whether we're making a foot orthotic for someone, which is a brace that comes, I don't have an exact example of it here, but here's one inside of this AFO. Is kind of an SMO, but supramalleolar orthotic, whether it's an SMO or whether it's an AFO height, SMO is supramalleolar orthotic. That would be more, again, for someone correcting the side to side and not the drop foot. When we have issues of side to side positioning, that's important management no matter what type of orthotic design we are making. So as a result, I would say that one of the things we have to look at is how this foot is positioning when it's non-weight bearing and how that relates. So if you look at this person's foot here on the right, and right now I have the foot in a straight alignment below the knee. This picture is cropping that off, but it is. So when this person's foot hits the ground, they walk just like the gentleman in the video at the beginning of the presentation on the lateral border or outside border of their foot. So they develop calluses at the lateral head of the foot by that pinky toe, and then they develop calluses on the first ray. And the reason somebody who develops calluses on their first ray as well is because when you stand on the outside of your foot, your first ray, which isn't connected with the other four toes, drops down to the ground to give you some stability. So as you progress your weight line forward, that big toe has to drop down. If it doesn't drop down, you have a really unbalanced foot. But naturally, the body does that. So to balance the foot, what we typically do is we wedge the foot as you see in this drawing. So there's more wedging in the front part of the foot than the lateral part of the foot. So where this person has their worst callus, which is by that pinky toe at the ball of the foot, is where I'm going to put the most pressure from the ground up, which is different than the approach a lot of orthotists take. A lot of orthotists take the approach of cutting a big hole inside of the orthotic or dipping out the orthotic or putting a bunch of, like a donut pad there. And the problem with doing that is somebody who's collapsing laterally, that may feel good when they first get the orthotic, but eventually that deformity sinks deeper into that hole, and in time it becomes even more painful, and the alignment becomes really even more severely because that lateral side of the foot had to dip down more and the big toe had to go down even more. So by posting the foot in this direction, we're going to prevent that ankle from rolling out. We're also going to prevent those toes from turning in, and we're going to help then with that progression so then the brace can move up and down. So whether we're posting the bottom of the brace or we're building a foot orthotic that sits on top of a carbon AFO or a foot orthotic on its own, so like in the case of a blue rocker, I always recommend that we make custom foot orthotics for people who are doing this, so that we're doing two things. One, we're providing an orthotic that they can wear when they're not wearing the blue rocker, and two, so that we're controlling the stress that they're putting on that strut, or really any style of off-the-shelf or custom style carbon brace like that, where we need to control the coronal plane and transverse plane motion. We do that by the posting that's underneath the foot. So I think that answers both Rick's question that came up and as well as this patient. So the other thing I should say here is a callus is a sign of a biomechanical issue. So if you're developing calluses, that means biomechanically you're not distributing your weight properly across your foot. So in general, alignment could be benefited if you're developing significant calluses. So hopefully that's understood easily. So I was wondering if it is helpful at all to wear AFOs just when out of the house and go barefoot at home, or if I should wear them at home as well. So everyone's a little different here. The hope is an AFO is a tool for you to be enabled to do more. Certainly people who are more mildly involved may only choose to wear their AFOs for certain activities, like rock climbing or climbing a mountain or something like that, you know, and then when they do their day-to-day activities, if they sit at a desk all day, they may choose not to do it, you know. So the hope is if the orthotic is done right for a more mildly involved patient with CMT, you're able to use that when you want to use it, okay? If it is something that is more, you may feel too that you get enough benefit from wearing it that you find that you want to wear it more often, and that's more often my experience with patients is, wow, I just find I do so much better. Even at home I can stand more still. You know, I don't have to grab onto the wall, or I'm not holding on to things all the time. So the decision becomes you, and ultimately an AFO is your tool, and you use it how you like it. Now, what depresses me, I guess, a little sometimes is to find out that that tool is being left in a closet, because I feel like, well, maybe we didn't make the right decisions along the way, or we didn't find out enough about that person to really understand, or maybe that person didn't come back and see us and tell us there was a problem either. And you know, that certainly would never be my goal as a clinician. I would want people to have successful outcomes. So it's really important to go back to your orthotist and advocate for yourself as well too if you're having those issues. So I have two questions. What are your thoughts on the fat brace? Do you have any concerns or opinions with these types of AFOs? Which AFOs are more stable, hinged AFOs versus non-hinged AFOs, spring-loaded AFOs? Do you work with different types of AFOs in your practice, and do people with CMT do better with either type of AFO? So we fit people with CMT with all sorts of types of AFOs, and obviously we do all kinds of AFOs. So as an orthotist, I think it's responsible for us to do that. There are certainly practices that don't do any carbon fiber, and some of that is because although you see a big price tag being billed to your insurance, the other aspect of that in our field is the cost is significantly higher to manufacture those items, and maybe pay a manufacturer to be part of that, versus when we get to make a polymer brace that we can make in-house, saves us a lot of money in terms of fabrication costs. Even though the price tag may not be as high, my profit margin might be higher. So I certainly, as a clinician, feel a responsibility to get a best solution for the patient and not make those kind of considerations. There are certain companies and practices in the country who practice differently than that. So, so in regards to the fat brace, it's certainly not a brace for everybody. I have had failures and have had tremendous successes with them. Some of the issues with the fat brace are how they open up at first. The carbon fiber material does not go all the way over the foot. It is a very thin piece of glass material that surrounds the foot area. And the goal of doing this is to really get good control over those transverse and coronal foot positions by really gripping around that calf section, but also so that this dynamic strut can travel the best it can possibly with that foot. So it will load as the patient's weight and center mass move forward, and then it provides energy return. More than other style of AFOs, the amount of pressure that you can put in, the amount of energy return is much greater than a lot of other designs. The failures on these happen because there's delamination between the carbon material and the glass material. That can be rebuilt. Often the decision becomes, well, do we want to do that, or do I want to have a backup set, or, you know, those are some of the considerations. In terms of energy return, it does, at this time, to me, seem like the most energy return that you can get from an AFO system. and has been my experience with patients in terms of feeling fatigue and issues. One gentleman I fit them with was very close to working in, taking a wheelchair on family vacations and doing that, and really because his fatigue levels were getting so high. And he took his wheelchair shortly after he got them to a concert that he went to. He walked around for 3 days and didn't take it out of his car once, all because, and he wasn't anticipating that, but he didn't feel that energy loss that he was in his previous, and he was in other style of carbon AFOs prior to that. So I do think it's really has really great energy return capabilities. I think, if everybody could have different AFOs for different activities, that would be the perfect world, right? So this could be your most active set of AFOs compared to your walking in the store set of AFOs versus your, going on an airplane set of AFOs. So again, it's a lifestyle decision, and is this the right decision for you as a patient? So I think I'm getting, yeah, okay. So going about the hinged and non-hinged AFOs, so this is not a patient with CMT. I'll just clarify that. It's a child with idiopathic toe walking, so that means they don't really understand why this kid is toe walking, so there doesn't appear to be any neuromuscular reason. The reason I have him in this slideshow is because I want to demonstrate the unimportance of hinges, I guess. In general, we've avoided hinges with patients with CMT, and that's partly because one thing, when a hinge is meant to bend in a forward and backward direction. In a polymer system like this, if you have bilateral weakness in the muscles that help you here to stabilize your ankle, so it blocks all of your ability to push your ankle downward, but what it does is ensure then that as you strike the ground, you'll strike with your heel. Right, to maintain a stable knee position. If you don't, or you have stability issues, and you're wearing two braces like this, you may end up standing in this position or crouched position. So that's one of the disadvantages to a patient with a hinged system, okay, when the hinge is free in a polymer AFO. When we were originally seeing patients in Detroit, we were using a system like this, so a lot more freedom in terms of being able to push your ankle downward. It had a spring, so during swing phase that helped lift your ankle up. And what it does is then you hit this pin in the front here, and that helps you to rise forward, but also we would adjust the pin then so when you stood, your knee position was in the right place. But guess what? Even in this system, which is very solid, and I can't twist that foot underneath the cap, the CMT patients would break the bar right out here, or they'd come back a few months later, and this very nice looking spring that's inside here would be in tiny little pieces and look like confetti. So we started to look for the dynamics more in the material, and that's why we worked more with the carbon fiber bracing versus getting the dynamics from the hinges, because the failure rates were getting pretty high. So plus the other disadvantage to hinge systems are the bulkiness. So anyway, so I want to illustrate to you though how proper alignment inside of an AFO is really key, because this kid, for example, is walking on his toes. This is how he walks all the time. He's been walking this way since he was 1 year old. Now he's 5 years old, and they've never worn any kind of orthotic. So the issue is we can't lift his foot up any higher than what you're seeing right in this picture. So when we make his ankle AFOs, they have to be at that downward angle. They're really plantar flexed, like 25 degrees of plantar flexion. So what do we do with this child is we made those AFOs in that position, but then we wedged underneath the shoes, and you see there's kind of a rocker motion to those shoes too. But what's beautiful about this, and what this really demonstrates, are how good are his mechanics at his knees and hips, and how much longer is his step length, and his stability and standing. And so do we really care that his ankle isn't moving a whole lot inside of this AFO system? So the answer is, in a solid ankle AFO system, you really need to consider the shoe dynamics, and you need to, so if someone is being fit with solid ankle AFOs for a particular reason, the textbook answer is a rocker bottom sole should be added. Additionally, there should be consideration to what position the shank angle, or meaning the tibial section or the below knee section, is angled to the ground, because that has a dramatic influence then on the knee and hip mechanics. And we're really happy with how this child walked. Now, again, this child didn't have CMT, but the same alignment issues are important for anyone walking inside of AFOs, and that's why shoe wear is important to you as a patient as well. In this particular case, just so you guys know the outcome, because we restored heel contact for this child, that helped him to get a stretch reflex, and about 6 months after wearing these pretty full time, he's no longer wearing them, and he's in a foot orthotic, because really the reason he was walking up on his toes is for sensory reasons, and he never really experienced heel walking, so he never could get that stretch reflex that we all get when we do contact our heel. How that relates to patients with CMT, though, is if you have tightness in your ankle, pointing your toe downward, and you're not getting that regular heel contact, you're also in this paradigm of increased tightness because you're not getting that stretch reflex through those tendons. So I think that was probably a little confusing, but hopefully it makes sense. Anyway, do hinged AFOs or unhinged AFOs cause more stress on the hips or knees that would cause them to deteriorate? The specific answer to that could be that how I demonstrated before, that if you're not having good knee stability and you're creeping forward into a crouch position, that could be the case with hinged AFOs. And if an unhinged AFO or a solid ankle AFO is aligned properly, it shouldn't cause pain or stress on hips. Alignment is very key to doing that. Additionally, people suffer from hip issues with CMT when they have a particularly bad turning ankle, and it's usually the opposite hip to that ankle. So if your right ankle turns badly, your left hip is often the one that's going to pay the price for that. And part of that is because you don't spend a lot of time then on that affected ankle. You're shifting over to the other leg faster. You're trying to advance that leg faster. You're moving quickly. So that's why balance at that ankle would be very important. Working on better alignment on that ankle is very important. Controlling that coronal plane and transverse motion of the foot are really important for hip and as well. So I think that answers that question. So specifically related to those who are post-hip replacement, my real concern would be post-hip replacement is this. When they put a hip in, physicians generally do that the way that they know how to do it. Because if you have triplanar deformity happening at your ankle, that puts more stress on that hip joint that isn't really designed to move in a rotational way, the way your natural hip or really most hips would move anyway. So there may be increased stress between the bone and where that prosthetic, internal prosthetic is, that could cause. So ultimately the lesson here is try to manage your ankle alignments the best you can and your biomechanics at your foot and ankle to limit the stress then on the hip replacement. I'm an older woman with late onset CMT and have been wearing AFOs for 11 years. I now need braces that will give me some propulsion and will enable me to stand still and not shuffle backwards. So there's a little bit of a paradox also stable. So in general, that's why we use carbon fiber bracing. And part of the advantage, sometimes when people have been so used to seeing AFOs in a traditional way where they come behind the calf and then they see an AFO that comes in front of the leg, they're like, well, how is that really going to help me? So that's one of the things that they like, that we like. This is a newer design from a company called Autobach, the walk-on reaction. One of the things I like about it is the strut is not on the outside of the foot, so someone who turns their ankle outward won't necessarily run into the strut issue. The other thing is they send as an option this strap, so someone who's turning that ankle out badly, sorry, I got all tangled up here, badly could put their foot in here, and additionally, to prevent your ankle from wrapping, from going around, this isn't going to work perfectly because I don't have a foot inside of here, but additionally that can help draw you so you're not pulling so far apart away from the brace. And then by being in the front of the leg, the advantage to that is you're giving some more stability in mid-stance or for standing still, so that the knees don't have to do so much energy to fire those muscles and to keep you in a static standing position. So this is again a newer design. Whoop, they get some dynamics. My table is very slippery, not only through the table, through the foot plate itself, but that strut where this bend is also gives the dynamic bending. This is German design, so I have some good faith in that they did some testing on it, and I've had good success with some CMT patients with it that couldn't do well in the blue rockers because of the strut position. I should also mention that if you loved your blue rockers, there is an opportunity to get a custom version that they can change the position of the strut, they can increase stiffness, decrease stiffness, they can increase kind of the height where it's coming up, so if that's the problem that you're experiencing. Again, there's some important things that we do to these to prevent them from breaking. I haven't done this to this particular one, but sometimes I'll just put a stabilizer underneath it so it won't rock back and forth inside of the shoe. That helps prevent stress on the strut. And then we build a custom foot orthotic to manage the side-to-side alignment and the transverse position of the foot. So I just hit the hour mark. We've got a bunch of questions that I'm going to try to get to still. So I'm going to go a little bit quicker. How important is the orthotist experience with CMT? I think it's somewhat important. I certainly have changed my progression of orthotics, and obviously I think my experience with CMT has helped me to make some better decisions most of the time. But I think each patient's very unique and will have very unique challenges. So I think it helps to have somebody experienced with CMT. I don't know that it's the end of the world. If you're in an area which maybe you're having trouble finding someone, I would suggest looking for somebody who is experienced with dealing with patients with neuromuscular conditions. So I think that's a good suggestion. Is there any harm in putting off getting an AFO for as long as possible, assuming that one doesn't injure oneself in the meantime? So kind of answering their own question there, but so the goal is to not injure yourself. And there could be secondary harm in terms of how your muscle groups are turning on and turning off up your leg, how you're putting stress at your knee and hip joint. What I would encourage somebody who's more mildly involved is get a very flexible AFO that you use some of the time, and it becomes a tool to use and enable you to maybe do a little bit more. I had that shopping cart in the one ad. One question I sometimes ask what is your desire to go get that one thing? Are you going to get it even if it's in the back of the store, or are you just going to give up on it because of the walking aspect? So and sometimes mild the thing about CMT is sometimes the patients become a little more inactive just because no one injured you, no one tackled you on a football field, and all of a sudden you can't do something. It just so slowly happened over time that it might be a good consideration to get involved in early on and just use it very little, but hopefully it's a good tool for you and finding the right mixture. So do you have any thoughts on the Helios brace? I get this question often. I would generally say that I think it's a valid AFO for CMT patients. I think there are lots and lots of today. Again, listen to our talk in Orlando and it'll give you more details about specific AFOs. But there are lots of dynamic AFOs, and I think even that design has its own challenges in terms of, like we all have challenges, matching the right brace to the right patient. And even though that brace may look similar, they make decisions on stiffness that if that decision is not made entirely right from the get-go, that's what you're stuck with. So, again, I think it's a bit of an issue and a challenge. So I don't see it not as a valid option or choice for someone with CMT. I just hope you know that there are lots of other choices and other opportunities out there. So are there any promising new products on the horizon? I have kind of a conceptual idea that I'm speaking to a manufacturer with that has a dynamic strut that I envision we would be able to basically have a foot plate and a calf section, and that dynamic strut would be able to be pulled in and out, and you'd be able to change it. So maybe for one activity you'd want this level of stiffness, another activity you'd want, even in the sense where as an orthotist I'm fitting it to the patient, and okay, I thought stiffness 3 was the right decision for the patient, but it's too stiff, so we got to go down a stiffness level, or vice versa. So I think a modular system like that really makes a lot of sense to me, and I hope that through my discussions with this group that we can get to some R&D and hopefully work on that. I think there's always new products coming out. I showed you one that just came out at the end of the year last year that I'm pretty excited about for patients with CMT. And then, even some of these designs like the noodle from Kinetic Research, there's so many different designs that company offers. This is a more stiff version where the strut's on the inside of the leg, but they have this nice panel that comes down on the outside of the leg. The advantage to that is that it prevents your ankle from rolling out, but doing so in an area, and really a nice way to control that ankle from rolling out without putting too much pressure on the ankle itself. So pretty comfortable to patients. So again, less dynamic but more stable, so finding that right decision for the patient. So please comment on knee hyperflexion. Really we call it hyperextension of knees caused by hinged AFOs. So really a hinged AFO should prevent knee hyperextension if it's at the right angle. If you're still hyperextending inside of a hinged AFO, then this angle should be addressed, as well as perhaps the shoe angle. In general, this child's hyperextending just on his left knee, and he does it later in stance, which is a common issue for people with CMT as well. Or if they stand still, they lock their knees back into hyperextension. So there is definitely the case where you may need a more solid ankle approach in these situations, or I would say something that prevents you from going back that way. There are certainly times that, you make that decision to cross the knee. I've made that decision with patients. My preference is actually not to build one single system that crosses the knee, but to actually make a knee brace that connects in with the AFO so that you can wear it some of the time you don't, so it's modular for you. Excuse me. So that also would help. So knee hyperextension, so what you're stretching out when you're hyperextending your knees is you're stretching your ligaments, and to some extent, irreversible damage there. So, however, you can strengthen both your quadriceps and your hamstrings to not lock out your knees as much. So that may also be important to you. Excuse me. Okay. All right, question. How do people who drive with an unhinged AFO manage to do so safely, and recommendations? So, so a lot of carbon braces bend somewhat even when you push down on them. So in general, people are surprised by that. And a lot of people with CMT are actually driving more with their hip. So they're lifting up from their hip and they're pushing down probably than you realize. And it really requires very minimal ankle motion to move the pedals. The reality is it may be safer because if you have a significant proprioception loss or sensation loss, that you may be safer using hand controls, and you can put hand controls on a car and still drive with the pedals. The issue there, though, is your foot may come in contact with those hand controls if you are using the pedals sometimes too, if they're not carefully done. One recommendation the physiatrist in Detroit used to make frequently to patients was that if you thinking about hand controls, it is a requirement of a rental car company. If you request them by ADA standards, they have to provide them for you. One of my best friends is in a wheelchair, and we've been across the country on road trips. And let me tell you, if you request them, make sure they do it for you in advance to you getting there, because they are not very quickly put on, and car companies aren't very good at being responsive to that sometimes. That's been our experience. But if you want to try it, you can always, next time you're renting a car or rent a car for a day, request that that's done and you can try it. There are also driving schools and places that you can try it as well. Some hospitals coordinate that. As I've been on that road trip with my friend, I've driven the car with the hand controls. It's really not a hard thing to do. And if it makes you safer inside of a car, certainly something to consider. Please comment on carbon fiber AFOs. Are they worth the extra cost? To me, they are, in terms of the dynamic aspect, as well as profile, as well as you know, just the experience for patients in general is much better. You know, one of the things in terms of transversely, I cannot rotate that transversely. It's only bending in this sagittal plane of motion. And then the foot orthotics would help then with the coronal plane, or posting the foot to the right position. In terms of long life, a lot of that is, are we picking the right dynamic for the patient? Are we controlling the mechanics of the foot in those other two planes? So that's part of the issue. You know, CMT patients break plastic AFOs all the time as well too. So you know, I'm not sure that I can quantify the relationship of what's breaking faster one way or the other. So you know, I don't know exactly. To me, it sounds like you have an orthotist who's not very willing to work with the materials, so something to consider. Does everyone know about the Bury Your Brace website? Now you do. I'll also plug the cmtausa.org website. That's where my talk from Orlando will be up shortly. There's a whole bunch of other doctors that are talking in that seminar too, so it'd be something good to view if you have the time. And then this will also be posted on there in the reference area in the future as well. And I'm better off waiting as long as I can. I think I kind of talked about that earlier. This gentleman was upset because his toe-offs were actually breaking every 5 years. So, you know, he gave quite a bit of history here, and I think it, you know, he's walking well on those, or at least from what. But his concern is that they break every 5 years. I personally feel like 5 years use of any item that you're using on a daily aspect is pretty good, and perhaps though, using a custom orthotic would help significantly more, or trying one of these other off-the-shelf carbon fiber braces as an alternative. If that big problem with the custom orthotics, lift my foot without being so rigid that I can't walk. Yeah, so sorry, there's a lot of detail there, and I want to get to some of the live questions. If you can't lift the front of your foot on your own, does lifting it with your hand or a band help? Stretching absolutely helps. Yoga is great for that. Also, specifically talking to your physical therapist, very reasonably, not everyone's going to be able to do yoga because of the balance issues, but some of those stretches would be helpful to you. And any kind of loss of range of motion is something that makes everybody older. Gain range of motion. And when you have muscle imbalances, you have a tug of war that one muscle's pulling and the other isn't. So protecting that joint and doing a daily stretching routine is very, very beneficial. Is it better to wear an AFO all day or just wear it when outside the home? I think I've kind of answered that. But my point in putting this question up there, you know what? This person has two different tools. They have an AFO they wear outside the house, and they have an ankle splint. What works for you and is functional for you, great. You know, just whatever it is that enables you into your activities. So, Rick, do you want to ask some of the live questions?
We had several more questions that were submitted during the presentation, many of which you answered later in the presentation, which is terrific. But I wanted to just call out a couple of them. One of them was, what are the best brand of shoes for AFOs? Do you have any recommendations on that?
Yeah, I mean, so let's not just say AFOs, but let's also say CMT, because there's several issues with fitting the foot with CMT. Certainly we like a lot of the shoes that Atrex supplies, and they've joined a partnership to provide some benefits to those of you who've joined the CMTA. So I would certainly look at their catalog, as well as New Balance we like, because besides making the foot higher, the changes, your foot's wider, so buying width is important. It's also important, excuse me, so you're not buying too much extra length in your shoe. A lot of people will compensate because they need that width by buying just a lot of extra length. That's not necessarily the best decision biomechanically.
And New Balance tends to offer shoes in various different widths, right?
Yes, exactly. Yeah.
Here's another question. She says, I was looking at a blue rocker and I was told that I have triplanar issues. Does the blue rocker correct for the triplanar problem you described? If so,
yeah,
how?
I mean, I think I talked about that somewhat. It bends just in the sagittal plane. I would include a foot orthotic, okay? So if they're not building a foot orthotic on top of the prescription. Okay.
Here's another question. Is there a benefit to using the AFO during the night to keep the foot tendons a bit stretched?
So yes, because the duration of stretch is greater then. So there are nighttime stretching splints. Sometimes we make them custom. Sometimes they're off the shelf. If your ankle's twisting a lot, it's good to be in a custom one, because that will not only stretch your ankle up, but it will also prevent your ankle from twisting as you stretch it up. There are some off-the-shelf plantar flexion night splints. Certainly if you're dealing with tightness issues, it certainly helps. That being said, if you get a good heel contact in a good daytime AFO, that helps with the stretch reflex. And because that's active walking, it may be even a better stretch than the nighttime stretching. So if you've got your daytime AFOs really figured out and you're still having nighttime stretching issues, then it's not a bad idea to consider a nighttime splint. Maybe wear one foot one night and the other foot the other night and switch back and forth. Certainly you can do that with some of the off-the-shelf designs. The other idea there too is that, lost my train of thought.
Night stretches.
Yeah, right. So and then getting into a stretching program. Sometimes even a nighttime stretching splint, like if it helps you when you're watching TV at night, where you put it on, you pull it up a little bit more during commercials so you get a more significant stretch and then relax again during the program or something like that is a good way to, and then maybe if you're watching TV for an hour, you're at least getting an hour of stretch during that period of time versus, for some patients, just sleeping with something on their feet is just not a tolerable thing. Other people sleep with their feet very pointed downward. So even sleeping with them at a 90 degree or even a little less than 90, but not pointed downward is better. Even if there's not significant stretch, maybe it's not as bad as a significant plantar flex position. Okay?
I know we're running late here, and appreciate you giving us as much time as you have, Sean. Let me read one last question, and then I think we'll call it.
I got to call the babysitter.
Is there any way to make an orthotic for the blue rocker that's not so bulky? My daughter's foot is partway out of her shoe when the shoe is on. She loves the blue rockers because she can walk faster, but I don't know if her orthotic is bulky because of her high arch.
This is a hard question for me to answer without seeing it. It could be that the bulk was needed to correct the alignment. So the amount of wedging that was required to really correct the alignment was necessary, so that the bulk then therefore was necessary. It could be the materials the orth just selected, and perhaps there's a way to do that better. That's a really hard thing to say without seeing.
Well, thank you very much, Sean. It's been just amazingly informative for you to share all this information with us, and I think I speak on everybody's behalf by, again, thanking you for making the time, and I'll remind everybody that if you missed part of this presentation or know of somebody that would benefit from it, you can see it in about a week once it's posted at the CMTA USA website under the Resources tab. So thanks again, Sean, and have a nice day.
Thank you. All right, have a good evening, everyone.